Hello, my name
Uh,
is Abeer Hani. I'm a clinical assistant professor of pediatrics and neurology at the Lebanese American University in Lebanon. I completed my pediatrics residency training as well as my MD training at the American University of Beirut. And then I did my pediatric neurology training at Duke in Durham, North Carolina, and then I follow. This was followed by a one-year training in epilepsy, clinical neurophysiology, and intraoperative monitoring, also at Duke. I completed my training in 2015, and then joined the Lebanese American University to start my work as a pediatric neurologist and epileptologist there. Thank you for this important question. So, the first thing is confirming the diagnosis. So, once we have a child coming with his parents or caregiver with concern for epilepsy, first and foremost, we need to confirm that they have the right diagnosis, that they're having epileptic seizures. And once we confirm the diagnosis with a good history, good physical exam, and doing some ancillary tests like an electroencephalogram, an EEG, and most often also we will need to do brain imaging in the form of MRI of the brain with or without other tests or investigations. Once we confirm the diagnosis, we usually counsel the family about what epilepsy is, give them education about how to handle seizures, and discuss with them the management plan that often starts with medications, specific medications that are targeted to the type of seizures that the child is having. Thank you for your question. We do have a lot of FDA approved medications now for epilepsy, and we have some medications that we use that are FDA approved at older ages, but we tend to use them a lot in some kids who have epilepsy. I think that the older generation anti-epileptics were very effective, but the side effect profile was a little bit more extensive, like the valproic acid. But valproic acid remains a very important drug and a very effective drug in certain types of epilepsy, and especially the more medically resistant ones. Ethosuximide is the number one treatment for a special type of childhood epilepsy called absence epilepsy, and it's our first line still. So, depending really on the seizure types that the patient is having, we have to try the medication that we think may work best. And then sometimes patients may not tolerate the medication that is the gold standard or the most recommended, and we have to resort to other medications. So, knowing of the knowledge of the different anti-epileptics that are present, especially that we have several new ones that came to market with newer mechanisms of action like lacosamide, perampanel, etc. These are important to be aware of those so that we can um, advise our patients to take the right medications. Some of our patients may not respond to a certain classic anti-epileptic, and we may need to add more than one. Add another anti-epileptic, so it helps to know of the newer generation anti-epileptics as well. Yeah, that's a great question indeed. So before we weren't able, or we didn't know that much. We didn't classify epilepsies into autoimmune, or we didn't have the facilities even to test for genetic abnormalities when we wanted to. However, the recent boom with the autoimmune discoveries, as well as with the genetic testing, with the next generation sequencing, now we have the possibility to check our parents and our patients for these possibilities. And I think the more the more specific your diagnosis is, the more potentially targeted your therapy could be. So yeah, I think when we have the financial capacities, and sometimes we do suffer from that, in that our patients are not able to afford certain expensive genetic tests. But whenever we have the feasibility to do these tests, sometimes that helps us to be a little bit more focused in our or more targeted in our therapy. Yeah. So basically, we have set guidelines at the American Clinical Neurophysiology Society with leaders in the field on how to do electroencephalograms for children as well as for adults. And so there is the minimum requirement, the minimum number of leads that we place on the head of the patient. And we think that to do a decent EEG, at least like 16 to 21 leads would be needed. And making sure you have a well-trained technologist who can detect artifacts. And this is the biggest problem we run into whenever we do EEGs in general, the artifacts, who can minimize these artifacts, who can detect the artifacts, and who can do the provocative procedures needed for the EEG. This is quite important. Most machines now are pretty good in terms of having good amplifiers, and so they can very well amplify the signal that we're seeing. But the human element, that having a good technologist and a good epileptologist to be able to perform a good EEG and read one remains very important, and that's why the guidelines should always be consulted. So in my experience, I think the best thing to do is to know how to deal with children and with parents. So with time, our technologists get the feel for how to approach a child. I believe that you can do the best quality EEG with all the leads on for all children, including babies, permitting that their head circumference allows it, as long as you know how to approach the family and the kid, kind of getting the technical expertise of like calming the child, making him enjoy the experience is a big issue. Explaining the procedure to the family and the kid are big issues. Now there are caps, like EEG caps, that the child can wear, and they can do a good job, but I think it's not as great of a job as the standard classic EEGs, whereby you hook the electrodes immediately to the head. So there are some shortcuts, there are some alternatives, but I think that training your technologists in your institution to get more familiar and more comfortable dealing with children is the best way to get the best EEG results. So most of the studies that we have with deep brain stimulation that I'm aware of target more the adult population. There are probably some that are starting to target the peds population. As far as deep brain stimulation, so there are the stimulation techniques like the repetitive nerve stimulation, the RNS, that surfaced several years ago. I don't think still it is, we are not using it in Lebanon, so where I work and practice now, but I think it could be a possibility in very targeted patients who have a focus for their epilepsy that is eloquent, that cannot be resected. For the deep brain stimulation that involving the thalamus or deeper structures, I do not have a lot of patients who have benefited. I don't have any patients who have undergone such a technique. So I think we're still in the early stages when it comes to pediatrics and these techniques. Absolutely. And this is probably the biggest part and the most important part that we have to pay attention to as pediatric neurologists or epileptologists when dealing with children with epilepsy. The family has to be on board. The family has to understand what's going on, has to understand the disease, because they are our best allies. They are the ones who are going to be able to watch whether the seizures have stopped or are still recurring. They are the ones who will provide for the medicine and ensure that it is given, especially when you have a child. So you cannot rely on the child taking his own medicine. So family education, making them understand the disease, the pathophysiology, the plan of action. I think one of the biggest things you need to let the family know as well is that taking a medicine, especially if you're starting the medicine, is not a guarantee that no seizures will happen. Because what I often see in my practice, I have the patients who come to see me for a second or third opinion, and they're taking 3 or 4 antiepileptics at very low dosages each. And so whenever a patient would have a seizure, parents think the medicine is not working. They demand that a second medication be added on top. And now you have a bunch of medications, um, all at suboptimal doses that are not doing their job. So it's very important to educate them that we will be starting a medicine, but that doesn't mean that seizures would stop right away. We are starting the lowest allowed dosage for your child's age and weight, and we need to watch and we need to observe. And if they have further events, we may need to up the dose until we reach the maximum dose or we hit side effect. I also counsel them about the possibility of the very low possibility of SUDEP, sudden unexpected death of epilepsy, usually in the second or the third visit once they've been on board and they're cooperating, and hopefully things are resolving, seizures are getting better. We discuss surgery, the option of surgery once they fail two or three anti-epileptics at good dosages. So we go there, we discuss it, and we discuss what that means. Definitely, repeatedly, we repeat the first aid recommendations or instructions if the patient has a seizure at home, what to do. And we revisit periodically the allowed or the restrictions we may be imposing on the children because of their epilepsy. So that's a very important part of what we do in clinic.